All right, computer's back up and going. For some reason, I've been deferring an update for the last 4 hours, and it decided to that it was going to force me to do the update. So apologize for getting on here late. Um, Tonight we have two chapters to cover. Chapter 4, which is over endocrinology, and chapter 5, which is over immunology, so like allergic reactions. Um, I think combined, it's like 130 slides combined for both the chapters. So my plan is, it should roughly take 2 hours, I think, to get through both of them. There is some stuff in endocrinology that I hate throwing big terms in here, but it is what it is. I'll try to explain it the best I can. Some stuff that I'll be honest, if I don't understand it totally, I'll be honest with you guys. I'll say, hey, refer to your book on this, because there are things that I don't know. I'll be honest with you. Immunology is pretty straightforward. It's about allergic reactions, how we're treating them, signs and symptoms to look for, how your cells respond. So that shouldn't be anything new to us. But let me get my screen shared here. Does anybody have any questions before we get going? No. Okay. Probably 7 o'clock. I'll give us a 10-minute break. So if by 7 I haven't given us a break, remind me, and we'll go ahead and do that. So let me get this figured out real quick, and then we'll get started. All right, so chapter 4, starting off strong. Endocrinology. What do we know about the endocrine system? Somebody just randomly give me some answers. What does the endocrine system consist of?
A lot of glands.
Okay, a lot of glands. Absolutely.
Like your thyroid gland, your pituitary gland.
Pituitary, thalamus gland, hypothalamus. There is a lot that goes into endocrine. And if I think that is something I would be writing down, I will try to give you the best hint that I can, because a lot of the disease processes that are covered in endocrinology are potentially going to come up during your national or whatever it might be. So just a heads up on that aspect of it. All right, so endocrine is linked not just to our nervous system, but to many different organ systems within our body, to our central nervous system, to how our kidneys are going to work, so our renal system. It can also have a play with our cardiac system, because the endocrine system helps with energy, right? Glucose. If we don't have glucose, we don't have one of the two things we primarily need for energy, which is oxygen and sugar. Just like many of the different processes of our body, it has messengers. We talked about our nervous system last time. Well, our nervous system has messengers as well. But the thing is, with our endocrine system, they're chemical messengers. So they are chemicals that are released or secreted, such as, let's think of one. One could be epinephrine. One could be acetylcholine. Those are different types of hormones. And they do this through what we call our endocrine glands. Our body has a ton of endocrine glands when it comes to it, to be honest. Do I know what every single one controls? No. Did I know what every single one controlled at a paramedic school? No. But I knew signs and symptoms to look for. You're not going to remember every single thing about the endocrine system. You're not going to remember every single thing about any chapter we cover. I understand that. I completely get that. Just as long as we understand the basic fundamentals of it. So, endocrine glands are ductless. We know that other glands have ducts, right? Kind of like think of like your tear ducts, right? It's a small little passageway where fluid or material can travel through, usually excreting waste or to lubricate a certain area. Well, our endocrine glands don't have that, right? So what our endocrine glands do is they release hormones. We know, like pituitary gland, thalamus gland, all those directly into our bloodstream. It's sending those messengers out, and our body responds to them. One of the messages might be, hey, our blood sugar is running low. Please, let's release some glycogen within the liver. and the body hopefully complies when that does happen. So, such hormones, insulin, perfect example of a hormone, right? How does insulin work? Well, it actually works. It doesn't work the way we think it does. Insulin actually helps with glucose as well. It actually helps our body maintain glucose. And diabetics, they don't have this, right? So they have to take insulin, or they have to take a medication that mimics insulin, just to be able to have that normal bodily function, or that normal endocrine function, to where our sugar is regulated. So you should know what homeostasis is. Homeostasis is the perfect balance at which our body tries to maintain. And that's, our blood pressure tries to maintain homeostasis, our heart rate tries to maintain homeostasis by compensating. Just when we're sitting here, think of you sitting there on the couch watching TV. You're at homeostasis at that point. Everything's perfectly balanced. Everything's working how it should. If something goes haywire, the other systems in the body try to work to compensate for that, such as my blood pressure. My blood pressure drops. My cardiac system then kicks in and raises my heart rate to try and compensate for that drop in blood pressure. Metabolism, we should all know what metabolism is. It's how our body uses or produces energy that we need. We have something every day called our, I want to say GMR, but it's how fast your metabolism works during the day. How many calories does your body burn at rest? By doing nothing, just by expending energy. Everything we do takes energy. Our organs functioning takes energy. Our brain thinking takes energy. So we are burning off fuel by doing that. Our metabolism is still going, right? Don't think so much metabolism as it goes to diets or anything like that. But our metabolism is essentially the speed at which we work, the speed at which we function, the speed at which we process things, right? You can buy a really expensive computer that processes things really fast, or you can buy a really cheap computer that might be a little bit slower at processing. Our bodies can have a fast metabolism, they can have a slow metabolism. It just kind of depends on things that we feed our body and how our body is naturally, maybe based off hereditary issues, maybe based off of some other health conditions that we have. These are the major glands within our body. So we have the hypothalamus, the pituitary, your thyroid gland, your parathyroid gland, your thymus, your pancreas, your adrenal glands, and gonads. The ones that we are probably most familiar with are our pancreas here and our adrenal glands. Our pancreas assists with sugar production, or sugar maintenance, not production, such as insulin, right? Our adrenal glands, guess what they excrete? Adrenaline. What is adrenaline? Adrenaline is epinephrine. So that's how we get energy. We get an introduction of adrenaline. Our sympathetic system kicks in, that fight or flight, and we get an increase in heart rate. We get our pupils dilating. We're kind of more aware at that point. So if we have an adrenal gland that's maybe not functioning as it should, we could potentially have issues with energy, issues with our response. We might have delayed reaction times. All these different things can go into that. But we're going to look at these different glands and what they pertain to. Diagram looking at where these glands are located within the body. Some, not all of the body tissues that have endocrine function. Kidneys, right? Kidneys assist with filtration. They're absolutely going to have endocrine, play a role in endocrine production or endocrine release, or maybe some of those chemical messengers. Our heart, absolutely. Our heart is the pump, is the engine of our car. It is the main thing that drives us. Placenta, think of mother carrying a child. That's how the mother and child are able to share things. It's through that placental membrane. That's how nutrients is shared. That's how hereditary information is shared. That's how chemical messengers are shared. And then parts of your digestive tract. Our digestive tract also secretes and metabolizes things. You know, as waste goes through our body, it's picking up different parts of nutrients through that waste that we can use, that it can use to function. So our hypothalamus, we're going to go through each of those glands. Deep within the cerebrum of the brain. Am I asking you to know where the cerebrum is? At some point, yes. Are you going to remember it now just because we covered it last week? Probably not. But I do have those diagrams on D12. You might want to kind of glance over them as to where different portions of the brain are located. Cells from our hypothalamus act on both nerve cells or neurons. Remember, that's our messenger for our central nervous system, and as gland cells. Our hypothalamus, in layman terms, regulates some internal functions, and it releases hormones in response to those internal functions. If it sees an issue with a certain body process, it will maybe increase production. If it sees an issue, it could decrease production. These are the hormones that we are looking at secreting from our hypothalamus. Only ones that you're probably going to know, and I'll be honest with you, and the one I off the top of my head, if you ask me, hey, is GHIH a real thing, or is CHR a real thing, or CRH or TRH, I would look at you like you're nuts. But there are some key words here. Growth hormones are secreted from the hypothalamus. So if I have a hypothalamus that's injured, this could potentially delay growth in some individuals. Or if you have an overactive hypothalamus gland, it could cause people to grow a little bit quicker than they should. That's the big one that I would say remember from your hypothalamus gland is your growth hormones. There you go, perfect example. GHRH stimulates secretion of growth. GHIH suppresses secretion of growth. Just remember, hypothalamus plays a role in how fast we grow. It can stunt our growth and it can speed up our growth. I'm putting it in layman's terms for easy for note taking for you guys. Because if you try to remember exactly all this as it goes, good luck. It's going to be rough. Pituitary gland, we've all heard that before. It's actually pretty important as to what it does. It's tiny in size, right? Right there where it says size of a pea, divided into posterior and anterior pituitary lobes. So we have a front and back to this gland. Responds to nerve impulses from the hypothalamus. We know that the hypothalamus secretes growth. Maybe the pituitary gland has something to do with that as well. So let's see what it does. So our posterior pituitary secretes what's called ADH. ADH is kind of important to know. Antidiuretic hormone. If I say antidiuretic, what do you think I'm wanting the body to do? What does that mean? It says it right there.
Decrease
Retention of water.
fluid.
So a patient in shock, their pituitary gland will release this chemical messenger, this ADH, telling the body, hey, stop filtering, stop getting rid of any fluids. We need everything we have because our body's going into shock. We need to maintain our blood pressure. We need as much fluid as we can get. That's what ADH does. The other, you might have heard vasopressin. It was an old ACLS protocol. I really don't know anybody that carries vasopressin anymore. Was essentially did the same thing. Oxytocin, which can actually be a medication that we could potentially, some people might actually carry in EMS, goes by the other name Pitocin. Causes uterine contraction and lactation. It's also really good for stopping postpartum hemorrhaging, is what we might be seeing it give for it as well, due to causing contractions. Why would we see an increase in ADH secretion? Well, potentially due to dehydration. Remember, our body's trying to hold on to fluid, and in severe hemorrhaging. Same thing. We want to keep as much fluid as we have. You should probably, again, know what ADH is. If I say ADH and I say antidiuretic hormone, that's pretty self-explanatory. It's telling my body not to filter, not to get rid of fluid. Lasix is a diuretic. It causes us to get rid of fluid. If there was an anti-Lasix, it would make us retain fluid, which is what ADH does. Diabetes insipidus is kind of a newer term, I would say. I wouldn't focus so much on knowing diabetes insipidus, but when we get to the diabetic portion, it's going to be a little bit easier to cover later on this chapter. Caused by inadequate ADH secretion. So if I'm not getting, enough ADH, then my body can essentially be getting rid of too much waste. Or the opposite. If my ADH secretion is messed up, I could be retaining too much.
That'd be like your DKA patient.
Not so much in DKA, because in DKA, your body's actually trying to get rid of all those ketones. So, one of the things we can think of with DKA patients is, excessive sweating, excessive urination, excessive mucus production, because it's trying to get rid of that excess sugar that it has built up. As to where this would almost be the opposite. This is where our body is going to hang on to too much instead of getting rid of it. I covered this already. Oxytocin, natural form of Pitocin. I don't know anybody that carries any Pitocin by chance. Does anybody does anybody here know if their service carries Pitocin? I didn't think so. They can also give it to induce contractions for maybe they want to deliver a child early. When you get to do if you've been to labor and delivery, I don't think you have. I don't think it's open yet for you guys. But once we cover infants and everything, that'll open up for clinical. Labor and delivery, you'll see a lot of Pitocin given.
Pitocin's horrid.
Do what?
Pitocin's horrid. I've had it,
Uh-huh.
and the side effects afterwards are just unreal.
Oh, I can't say that I've ever been given Pitocin, which I hope not.
It increases your contractions so much that it's like you just are nauseous and feel terrible, and afterwards you're just like sick feeling. So.
Well, and in my OB rotations, I don't have the right body parts to be given Pitocin, but it actually can cause pain as well, is what I was told a lot by the patients.
It does. It's horrid.
Okay, there's two big ones that I want us to remember here from the pituitary gland as well. Thyroid stimulating hormone targets our thyroid, because we're going to talk about some thyroid issues coming up in this chapter as well. If we have an increased thyroid production or thyroid working how it should, or we have one that's essentially in overdrive, could cause some issues. We were seeing a lot with COVID patients, as their thyroid was kicked into Mach 10, and it was causing them to essentially, if you heard the term thyroid storm, it was causing all their vital signs to become elevated. Their blood pressure would be high, their heart rate would become high, just everything would increase in production for some reason. And then FSH, which is follicle stimulating hormone, targets those gonad glands or sex organs. Again, we'll talk about some of these here in a little bit when we talk about thyroid issues and disease processes related to our thyroid. That might make a little bit more sense when we get to that portion. If there's any females in here that know about prolactin, I'm not going to pretend to be an expert on it. I spent most of the day today looking over the slideshow and trying to figure out some stuff, and before I kind of gave up hope on prolactin itself. I'm not going to lie to you. I don't know anything about prolactin. I believe it helps with lactation, from what I had read, which, targets our mammary glands of women. So again, in anticipation for lactation. And I'm guessing that's released when or during childbirth or when the child is born, just so that mother is able to breastfeed their child.
It actually takes like a couple days before that prolactin kicks in.
Mm-hmm. And it's mostly after birth, correct?
Yes, it is. It's after birth. So.
Mm-hmm. And then growth hormone. Guess what? We see a lot of growth hormone. We talked about a hypothalamus. We have it's secreted as well in the pituitary gland. There's a lot of glands that have to do with how our body grows, how our cells grow. Are we having some sort of growth spurt? So when children have a growth spurt, it's because their glands have essentially grown themselves and are releasing more of that chemical messenger, that GH, that growth hormone, causing all the other cells in the body to grow as well. It's like fertilizer. All right, thyroid gland. In the neck, just below the cartilage of the larynx. 3 hormones. Thyroxine, so metabolism. T3, triiodothyronine, metabolism, and calcitonin, which lowers blood calcium levels. So your thyroid level has a direct correlation to your heart, because our heart uses calcium to help with muscle strength, to help with how hard our heart is contracting. So in the event that we have a buildup of too much calcium, our thyroid gland will release calcitonin to fight it, to essentially lower that level of calcium. And this could, be causing other issues in the body, like I said, such as increased blood pressure because we have increased contraction. Too much of something it can be harmful to our body. I don't care what it is, too much of something. Think of white blood cells. We have too much of those in the body. What happens? We could develop leukemia. We have too much sugar in the body. Guess what? That's diabetes. We have too much adrenaline. Okay, that could potentially be a thyroid storm or hypertension as well. So our body has these fail safes to try and lower different levels than our body, calcitonin being one of them. People that have osteoporosis, this is a good example, have an increased production of calcitonin. So, my bad, it's the opposite. They don't have enough calcitonin. Their body is essentially either they have too much calcium that their bones can't absorb, or their body is not producing enough calcium because there is an increase in calcitonin. So it goes either one of two ways. The first time I heard that, I was like, well, how does that make sense? If you have too much calcium, wouldn't your bones just like absorb? I mean, if I just drink a bunch of, vitamin D milk, how does that work? Well, again, too much of something can be harmful to us. So when we have an overproduction of calcium, our bones aren't able to just literally suck it up like a sponge. Once they get a certain chemical messenger that says, hey, we need to bring in more calcium to help rebuild structures that are essentially debilitating or breaking down, that's when they absorb. If they're not getting that message, that calcium just sits there and essentially is doing nothing. Parathyroid gland also plays a role in potential osteoporosis in patients. Secretes PTH or parathyroid hormone, increases blood calcium levels. Weird. I just said if we have an increase in blood calcium levels, but our body isn't able to absorb it, we still have a breakdown of bones. So PTH and calcitonin go hand in hand. It's a perfect balance. It's that homeostasis. Remember, we have to have a perfect balance of both those to maintain the perfect level of calcium. so that when, go through a metabolic panel or somebody draws labs on us or whatever it is, maybe for a physical, there's a certain range that our calcium has to be within. If it's out of whack, we could look at one of these glands potentially being the issue, and then you go through testing just to see what is essentially causing problems within your body. There's always a yin and yang in our body. There's always that we have to have a certain amount of each thing to create a perfect balance within our body. That's honestly, that's what 99% of our endocrine glands are doing, is helping maintain homeostasis by releasing one hormone. Okay, well, that caused this. Okay, let's release this hormone to try and counteract it. Thymus gland, during childhood, it secretes thymosin. I'm not asking you to remember what thymosin is. Promotes maturation of T lymphocytes, which are responsible for cell-mediated immunity. So remember this. Thymus gland has to do with allergies. As children, we become exposed to things, different sicknesses, different allergens, different antigens. Our body then releases that thymosin to try and essentially figure out whatever this foreign body is and maybe build up a tolerance to it. That's why some people, like me, for some reason, I can walk through poison ivy and it doesn't affect me. I don't get itchy. I don't get rashes or anything like that. And it's due to a secretion within the thymus gland. Do I know exactly which one? No. But it has to do with how your body develops immunity to certain things. Pancreas is super important that we know. This last word in this slide, the tissue in the pancreas is known as the islets of Langerhans. I remember that term coming up in my national registry. Anytime you hear islets or islets, whatever you want to pronounce it, of Langerhans, they're referring to the pancreas. The problem with that is that also is where we are going to be able to produce insulin, right? That's what our pancreas is helping us with, is insulin production. Insulin is nothing more than a mediator. It helps us insulin is essentially a bridge to allow glucose into the cells. If we don't have enough of it, we have a buildup of glucose until we give that patient insulin, and then we watch their glucose level come down. It's not because insulin fights glucose. That's not how it works. That's what I thought for years. It's because insulin is the hormone to allow our body to absorb glucose. So if we're low on insulin, our body just has this massive buildup and doesn't know what to do with it. That's why these patients take injections, is to allow that glucose to be absorbed. So our pancreas plays a direct role, actually the most important role, in maintaining our blood glucose level. Diabetics have a problem with their pancreas. Glucagon increases blood glucose. Weird, it's a drug that we give. It's just not very rapid when we do it. If we give glucagon to a patient, it's releasing something called glycogen stores within their liver. Those stores are essentially a reserve. That's Fort Knox of our body of sugar. When we can't get an IV on somebody or their body just isn't able to produce enough, we hope that they have some money in that Fort Knox to bring their sugar up. Glucose allows that to happen. And remember, insulin is nothing more than a bridge, allowing glucose to do its job. If the bridge is taken out, guess what? Glucose can't get into the cell. Different types of cells produced by the pancreas and the islets of Langerhans are your alpha, your beta, and your delta. Apparently, C wasn't good enough for him. It didn't make the cut. We just bypassed that one. So that islets of Langerhans, I hate the term. Just call it endocrine tissue. That's all it is. That's why people that have pancreatic cancer have an issue maintaining blood sugar levels. So our alpha cells produce glucagon. Glucagon stimulates the breakdown of glycogen. Kind of like if we give glucagon, it releases glycogen. Both contribute to homeostasis, raising the blood glucose level. Absolutely. When our body sees a drop in blood sugar, it will try to release glycogen. The problem is, if our liver isn't functioning like it should, we don't have a store of glycogen built up. That's an issue. That's those patients that D50 might be the only thing to get their sugar up. They have to have a buildup of glycogen stores. I had a cancer patient for the longest time that we would constantly go to that glycogen did not work on because she had liver cancer. Her body did not have those natural stores built up. So alpha cells produce glucagon, beta cells produce insulin. Okay, pretty simple. Again, insulin's the bridge to allow glucose into the cell. That's all it is. It doesn't fight glucose. It works with it. Delta cells produce somatostatin, which inhibits secretion of glucagon and insulin. So in the event that we have an increase in glucagon or an increase in insulin, our pancreas can essentially introduce this new hormone, which blocks either one from being produced. This is a lot of information. I apologize for throwing a lot of this stuff at you, but it had to come at you at some point. Adrenal glands locate on the top of our kidneys. Again, guess what they release? Adrenaline. Kind of makes sense. Norepi, fight or flight. That's our sympathetic system. When we're getting ready to run or we're getting ready to get into altercation or something like that, whatever it is, or we get excited, we get scared, we get anxious. That's our sympathetic system. When we're tired, when we're slow, when we've been up all night running calls, that's our parasympathetic system that's kicked in. It's slowing us down. I cannot tell you how important it is that you remember sympathetic is fight or flight, which is induced by norepinephrine, and parasympathetic system, which is rest and digest, which is induced by the hormone acetylcholine. If you can remember that, you're doing pretty good. Adrenal cortex. So talking about those adrenal glands, it also secretes steroids. Not like the steroids we're thinking of, like where somebody goes to a gym, takes steroids, it's really muscular, but different types of steroids, right? We can take steroids as well to help with our breathing. We can take steroids to reduce swelling, whatever it might be. The big one here that I like to bring up is that the adrenal gland can also help with salt and fluid balance. Water follows salt. Somebody has a really salt-rich diet, they also have an increase in water retention because water likes to stay where salt is, right? That's why they always say, if you're out stranded in the middle of the ocean, don't drink salt water because it just makes you more thirsty. Yeah, because you're putting salt in your body. It's thriving for more water at that point. That's why you eat a really salty meal, your body becomes really puffy. You retain a lot of water and you're not really urinating as frequently. Gonads, same for men and women. It's our sex hormones. Produces eggs in females, sperm cells in males. I shouldn't have to go through Sex Ed 101. Big things that hormones that we need to look at is progesterone and estrogen. Should be pretty self-explanatory. Responsible for sexual maturation for puberty and subsequent reproduction. It helps develop sexual hormones. It helps us develop natural hormone or natural processes in the body to help with reproduction. Estrogen, you have an increase in estrogen level. Development and maintenance of secondary female sexual characteristics such as breast development. Also plays a role in egg development and potentially protects against heart disease. Females are very at risk for heart disease when they take certain medications such as like birth control, right? That's the one thing that kind of guys, we're just at risk for everything. Females are a little bit more at risk when it comes to sexual hormone production, just in the role it can play on the body. Progesterone assists with essentially once, where you can read it there, assists with pregnancy. So estrogen, development of female sexual characteristics. Progesterone is assisting during pregnancy of a fertilized egg. Guys have testosterone. That's why you hear like all these testosterone commercials or testosterone replacement therapy, TRT, or TRH, testosterone replacing hormone. People that have low testosterone levels, common side effects are inability to sleep, decreased sex drive, weight gain. These are all things that testosterone does. Testosterone is what makes us men, essentially, right? I'm trying to think of an easy way to put this, or a polite way is the best way for me to think about it. So, and I'm not trying to offend anybody. If I do, I apologize. But in males that essentially want to undergo a transformation into a female, they will take estrogen because it will give them female characteristics. And it could be said for the other way as well. Females could take testosterone to give them more of a manly physique. Pineal gland, response to light. It's basically what tells us, hey, the sun's going down. I'm going to release melatonin. What does melatonin do? Causes you to get sleepy, causes you to get tired. Our pineal gland starts to notice light is increasing. It might naturally cut off the melatonin production to allow us to wake up, to help with our circadian cycle. That's why people that work night shift or whatever it is, you're essentially fighting your pineal gland. It has to get in this whole new rhythm. It still will secrete melatonin at night, which is why at some point, if you work night shifts, and when I say night shifts, I don't talk about working at a fire station and sleeping at night. I'm talking a true night shift where you're up 6P to 6A. At some point during that, you get tired. I don't care how long you've been doing it. At some point, your body starts to slow down a little bit. It's because that's natural. Our body releases melatonin when it sees dark lit areas, dimly lit areas. That's why a good rule behind, people that work night shift in warehouses or something like that, if it's really brightly lit in those areas, that's so your body doesn't get the urge to release melatonin. There's actually science behind it. So pancreas, we know that helps with insulin production, right? So if we have inadequate insulin activity, we could have an issue with blood glucose. That's diabetes. Insulin enables body to store energy as glycogen, protein, and fat. Okay. Our body feeds off that. Our body feeds off glycogen. Okay. It converts it into glucose. Protein converts it into glucose. Fat converts it into glucose. That's why people that are on a keto diet don't eat a lot of sugar or eat a lot of carbs. It's because their body naturally will turn to that fat store and start chewing away at it for energy. That's how people on the keto diet lose weight. Okay. Anabolic uses energy. Catabolic produces that energy. Easy way I remember anabolic. Whenever I think of anabolic, I think of anabolic steroids taken to essentially increase muscle tone, increase muscle production by using a ton of energy. It allows your body to use twice as much. Catabolic is just what produces that energy for our body to use. Again, insulin, it acts as a bridge to allow glucose into your cell so that your body can use it for energy. Sometimes the body cannot use glucose as primary energy source. That's fine. In those times, such as the keto diet, which I just talked about, your body slowly switches from glucose to fat as the primary energy source. If your body is not getting enough glucose, it turns to one of those stores so that your body can begin to break it down. That's why people on the keto diet also eat a lot of protein. It's because you're also providing energy to your body in that sense. Remember, it stores protein and it stores it in fat. It'll start chewing at both those. Ketone bodies are essentially the acid buildup that happens during DKA. That's what gives the people the fruity smell of their breath, is those ketone bodies. And then ketosis is essentially, again, when you're on the keto diet, you put your body into a state of constantly producing energy. So if your body's constantly producing energy, your metabolism is through the roof because it's constantly doing something. It's constantly functioning. The problem is ketosis, when we talk about diabetics, is what we call DKA, or diabetic ketoacidosis, which is generally a blood sugar. It depends. There's no straight across the board for each patient, but 400s, 500s could be a real big issue, especially if that's their normal. That's what they consistently stay at. Remember, sugar is very necrotic. That's when you can start to see blood vessels break down, potential for strokes, potential for heart attacks. This number, I swear, changes every year. Blood glucose levels lower than baseline, which is 80, reflects hypoglycemia, low blood sugar. I can tell you my resting blood glucose is 58. That's just my normal. That's what I sit at. The problem is I have a very low threshold for when my sugar starts to drop. And I can tell, and I'm not diabetic, but was it last week? I'm on a new medication. Doesn't make me really eat a whole lot. Problem is I forget to eat and I get really lightheaded. I get really tired, almost drowsy. I feel like I'm going to pass out and I know that's when I need to eat. That's because my blood sugar has dropped, right? So when that happened, I said, hey, I want to test this. I'm going to check my blood sugar to see what it is. My normal resting, fasting blood sugar is 58. Okay, no big deal. I feel fine at 58. I checked during that time, my blood sugar was 54 when I was feeling kind of low on sugar. So from 58 to 54 isn't a big difference, but that's just where my body starts to say, hey, you probably need to eat something. So what do? I introduce carbs to my body. Why? Because your body will break down carbs into sugar and it lasts a little bit longer. Hence the reason why we have diabetics eat a banana or peanut butter and jelly sandwich because it's a slower metabolizing carb than saying, hey, here's a bag of Skittles. All that's going to do is spike their blood sugar right then, and then they'll drop back down. That's why we had them drink orange juice or apple juice, because they're complex sugars. They take a lot longer to break down, but it also lasts a lot longer. Again, this is patient specific, but the numbers, anything 80, less than 80, they're calling hypoglycemia. Anything greater than 140, they're calling hyperglycemia. You know, I've told you guys a story about the patients that I've had that have sat in the 300s normally. So if you get them and you find them in 150, per the book, they're hyperglycemic. But for that patient, it is abnormal. For that patient, they are hypoglycemic. So that's why it's important to ask family, ask anybody that we can. I've even went as far as to check their glucometer. Most neuroglucometers store their recent blood sugar levels. And so I'll look through that if I can and see what their recent sugar levels have been. If I have a patient, their blood sugar is 150 and I check the last 4 days and they've been in the 350, 400 range, okay, I give them half an amp of D50, see if that maybe changes anything. If I start to see a response, I give the other half the amp. Glucose loss in urine can lead to dehydration. Okay, why? Water follows glucose into urine to cause what we call osmotic diuresis. Okay, not saying remember that, but again, there's some of this stuff on here that might click in your head. Big term that I hate using again is glycosuria, and that's the presence of glucose in the urine. Creates almost like a sweet smell. A lot of times they'll check people's urine level when it comes, or blood glucose level off their urine. And that might be during a physical, during a drug test. A lot of times it's done with pregnant patients, is they're looking to see how much glucose is in their urine, because that could also tell them with pregnant patients if they potentially have
Gestational diabetes.
there. I was drawing a blank. Thank you for.
Is that what they did? Is that the 24-hour blood, like urine sample where they collect it and do it over
Yeah.
24 hours?
Yep. And yeah, gestational diabetes, absolutely. Not sure why I was drawing a blank on that. Type 1 diabetes, very low production of insulin, in many cases, no insulin at all. Okay. People with type 1 diabetes have to take injections. Usually it's like Humalog or Novolog, whatever it might be. It used to be they had to draw it up out of a vial. More often than not, I assist in my grandpa's injections. It's almost like an EpiPen now. It has a little dial on the end. You know, it's not something we would generally be doing. It's something I've assisted a patient with before, which is perfectly fine. You turn the dial up, let's just say it goes 1 to 20. If they usually get 10 units of insulin, they turn that dial up to 10. They stick themselves with a small little needle on the end of it. I mean, it's tiny. And then they hold a button down on the pen that then releases the insulin into their body. Most recently, I had a patient whose blood sugar was super high, or what she thought was super high. It was high for her. I think it was like 350s, but she normally was hyperglycemic somewhat. So in my assessment with her, one of the questions I asked was, well, have you taken insulin today? And she said, no, I don't have my insulin pens. I'm out. I didn't get my prescription refilled. Okay, so I know what potentially caused this issue. And I said, do you have your pens here? I mean, I can take a look and just see maybe if there's any around. Looked at, she had like a whole bag of like 30 of these pens. Be careful if you have to grab one of those, because if the needle isn't capped on the end, you almost can't see it and you can stick your finger. And I only know that from my grandfather. So I checked all these pens, they're all empty. I said, hey, do you care if I look in your fridge? Have you ever had to take injections before the pens? And she goes, yeah. And I found a little bottle of insulin in there. Looked at the date was fine. Medication was cloudy. And I was like, God, I don't know if that's normal or not. And so I looked up this medication real quick and I typed in, I can't remember what exactly it was. And I typed in cloudiness, and apparently it brought up a bunch of pictures of it, and apparently that's normal for it. So I was like, okay, it's within date. There's no issues. It's still capped, hasn't been opened. Right on. Said, hey, do you have any syringes or anything around here? She said, yeah. Told me where they were. And I said, okay, ma'am, how many units do you usually take? And she said 10. Okay, so I drew up 10 units of insulin for her. And I said, hey, I'm going to give this to you. I'll have you just, give it to yourself as you normally would. So she did, no issue. And she goes, well, I really don't want to go to the hospital now. I'll call back and see, if I start feeling any worse, I'll give you guys a call back and we can go to the hospital. I said, okay, I agreed because she had her son there to watch over her. And I told him if something changes, please let us know. So let me tell you another part of this story where you can also have an impact is I like to call it community outreach. I know that we're not covering that in this chapter or anything like that, but I said, hey, do you have anywhere to put these needles or anything like that? And she said, no, not really. I haven't put them in a bag. And I said, okay, I'll take this bag from you. I'll dispose of it. And I said, if I get time, I might have a little sharps container at the station. I might run you one back out here. So 2 hours go by. We went on another call. I dropped the needles off at the station at the hospital. Went back to our station. We had small little sharps containers. And I said, hey, let's swing back by her house. We'll just check on her. We'll check her blood sugar level again. And we'll bring her this little container. So we got there. She was ecstatic to see us. She was acting a whole lot better. Blood sugar level had come within normal limits. I dropped off that little sharps container for her, and we were on our way. Was that wrong of me? No. Did I have a call for service there again? No. But I built trust in a resident. I built trust in them knowing that, we're not just here to transport you. We're not just here to collect a bill from you or anything like that. So sometimes, and again, I'm not saying that's what you have to do, but in her case, it made a difference. I'll transport anybody if they want to go to the hospital, but she didn't want to. And I said, okay, well, then we'll come back and check on you. It's the little things that make a difference in some patients. Type 1 is also called juvenile diabetes. Type 1 is less common than type 2, but more serious. Type 2 is where they just have a increase in blood glucose levels. So they generally have to take medication with type 2 diabetes. They generally take metformin to essentially assist with that glucose being absorbed into the body. So type 2 is medications, type 1 is injections. Some different things you could see in diabetic patients when their blood sugar level is high. Again, excessive urination because their body's trying to get rid of that glucose. Polyphagia or increased hunger because their body is trying to find carbs to be able to essentially break them down. Weakness, weight loss, constant thirst, because remember, water follows sugar, kind of like salt. They're constantly thirsty. I went over type 2. Again, they might require insulin. We don't generally carry insulin on ambulance. I'm sure being in the ERs, you guys have given insulin at some point to patients there. But things to look for with patients. A lot of times, I've had family members who are diabetic, changed their lifestyle, lost weight, were eating better and everything like that, and no longer required insulin injections and actually got their blood sugar levels within normal range. A lot of that can be changed with lifestyle changes, such as changing your diet is huge when it comes to diabetes. You have to know what to eat, especially if you're taking insulin, because what you eat can play a role in how much insulin you're going to take. Trying to think here. Nate or Blake, are you guys on here?
Yeah.
Are you at
Yep.
work?
No.
I am.
Okay. Who are you working with?
Dues, B shift.
Okay. Tony is a good person to ask about diabetes. He was a friend of mine going through paramedic school. He obviously he was diabetic, and he was able to tell us all sorts of different things we need to know about diabetes. Um, use people like that as a resource. And honestly, when you're in the hospitals, if you have a patient that has diabetes, they know how to treat their diabetes better than anybody. They know what they should be doing. They know what they shouldn't be doing. Use them as a resource. Talk to them. Hey, I'm just learning about diabetes. Can you, tell me, a little bit about what's going on, how much insulin you generally take during the day. They go see an endocrinologist usually. Maybe they have an insulin pump. I had a patient that commonly her insulin pump would fall out. So by the time we got there, she was unresponsive. Her blood glucose level was super, super high. I can think of one time we couldn't get an IV on her. I want to say her blood glucose was like in the 600s, or it just read high on our machine. I believe it depends on the machine, but anything over 500 will just register high on a glucometer. So we ended up starting an EJ just to give her a ton of fluid. Did it make a difference during transport? No, but there were some other circumstances as to why she had bad veins. I'll just leave it at that. But that was what we had to do to get some sort of access. All right, 5 more minutes and I'll give you guys a break. DKA, serious, potentially life-threatening, associated with type 1 diabetes. So associated with that decreased level or decreased production of insulin. With DKA, you have that decreased insulin, and you also have an uptake in glucagon, which is causing glucose to constantly be produced, which is constantly causing an increase in blood sugar levels. Depending who you talk to, DKA levels will vary. Problem is, again, the cells can't take the glucose because there's no insulin. There's no bridge to allow glucose to get into the cells. DKA, I want to say, I'm trying to look through here if it says levels. Wait, excess of 500. Again, most glucometers only go up to 500. So anything greater than that would potentially have an issue. Patients in DKA, some of the things that you might see with them: increased urine production, again, due to increased levels of sugar. Their body's trying to get rid of it. Dry, warm skin, dry mucous membranes. That's why they're thirsty generally all the time. Progressive sense of malaise, so they just don't feel well all the time. Our body naturally in DKA, a term that you should probably know or get used to knowing, is Kussmaul respirations, if you don't know about it, which is that very deep, labored, rapid breathing. It's because their body is trying to blow off the excess ketones. Their body's trying to get rid of the excess acid in the air. Remember our acid-base balance? Our respiratory system is one of the compensation methods. So our body's trying to blow off that extra that we have. I've never smelled it, I'll be honest, where they say fruity or acetone-like smell. You're actually smelling those ketones. They're sweet because they have an increase of glucose. Again, I've never smelled it. If you have, great, but it's not something I use as an indicator. These patients can go unresponsive, especially if it's left untreated for a long period of time. Signs and symptoms to look for, or not signs and symptoms, but maybe some assessment findings that might help. I have not, I'll be honest, I don't run a lot across a lot of patients that have medical alert bracelets. Or maybe I'm just a horrible paramedic and don't look for them as much as I should. Insulin is something I will look for. Generally, if I have an unresponsive person, it's just me, more than me and my partner. I've got a couple extra hands. And I'll send somebody, maybe, hey, go look in the fridge, look for anything that looks like a medication, look for anything that looks like a vial. Look to see if they take any medications. I want to know what they are. Just to kind of get an idea of what's potentially going on with this patient. What do we do for them? Give them fluids. That's all we can really do during transport. We're trying to thin out the glucose level by giving fluid. Let's take a break right here. And then we'll come back. We'll talk about HHS or HHNK or HHNC, depending on what you want to call it. So let's take a 10-minute break, and then we'll come back and go through this stuff. All right. We've got like less than 30 slides to go on this PowerPoint, so we're zooming right along. All right, where we left off was DKA. Again, that was an excess of about 500 for blood sugar level. We have what's called HHS. You might hear HHNK or HHNC. Hyperglycemic hyperosmolar non-ketotic is what that stands for. I prefer HHNK or HHNC. I don't want to pronounce all that. So this is where we get dangerously like super high levels of blood sugar. This is where we're exceeding 500. You can see some patients at HHNC or HHNK that even sit in the thousands. These are super sick patients. And the problem is they cannot maintain, their body can't maintain that homeostasis anymore. As you see there, causes osmotic diuresis to produce dehydration, water intake inadequate to replace lost fluids. That's terrifying. These patients can't maintain at all. Mortality rate higher than for DKA, 40 to 70%. A lot slower onset, but at that time, their blood sugar is slowly building. And this is due to a lack of treatment, due to a lack of maintenance of blood sugar levels. This can put somebody in a permanent coma. As far as we're concerned, we treat them the same. We treat them with fluids. We're trying to thin down their blood level, right? Again, this could be 650, 700, up to 1,000 as far as blood sugar levels. Is there a set number? No, but maybe something to ask at the hospital next time you're with you can talk to a doctor or a nurse or whatever. Ask them what levels they would consistently call HHNK or HHNC. Some people might just call it DKA, but when we hit that threshold above a certain blood glucose level, and again, it kind of varies, but I want to say it's 600 to 1,000 roughly, which is terrifying considering a normal is 80 to 100, 60 to 100. Hypoglycemia, we're familiar with. Patient takes too much insulin or uses or excretes all their blood glucose and isn't refilling it, like in my case. I didn't like pass out or anything like that, but you can tell when your sugar starts to get a little bit low. Maybe you skipped a meal or something like that. Especially if you're trying to be on like a strict diet or whatever it is, your body is literally using up every cell or every nutrient that you are feeding it. So when you skip a meal or whatever, that could potentially cause issues. It could cause your blood sugar to drop. We've all seen hypoglycemic patients. They can tend to be violent. They can tend to be just kind of acting bizarre behavior, especially if family calls says they're not acting right. It can put them into a seizure. That's why on seizure patients, we should be checking blood glucose on all of them. Check a blood sugar on all your unresponsive patients. I mean, I shouldn't have to tell you any more than that. Check a blood sugar. Try to find out what the normal baseline is on patients. What is their normal blood sugar, right? If patient is awake, treat them with oral glucose, orange juice, complex carbs, sandwiches, peanut butter and jelly sandwiches are great. Fruit, such as bananas, great. If not, give them your oral glucose to chew on. Some people have glucose tabs. That's a thing as well. I know after my little event where I felt my sugar dropped, I bought a thing of glucose tabs. God forbid, I skip a meal or something like that again. And part of it's, I changed my diet. I'm trying to eat a little bit better. So my body's kind of in shock. And if that ever happens, okay, crap, I forgot to eat. I'm feeling that way again. It's like a little, I don't know, it's like a vitamin is what it looks like. If they're unconscious, look at giving them D50. Generally 50 mLs is 1 amp. 25 grams is in 50 mLs. I generally start it with 12.5. I'll give them half an amp to see what that does to their blood sugar. I hate giving a whole 25 because all that does is spike their blood sugar. When it spikes, they also come back down really quickly as well, unless you're having them eat complex carbs or drink orange juice or something like that. Some issues we can also see with our thyroid gland, hyperthyroidism. So when we have that, those are people that essentially could be really thin, really frail, because they have an increase in essentially the use of energy. That is what's called Graves' disease. So in Graves' disease, we will see, I was hoping I'd show it on here. We will generally see an increase in all of our vital signs. Increased respiratory rate, increased pulse, increased blood pressure. Graves' disease is kind of important that you know as far as NREMT goes. A lot of these disorders are things you should probably know. So put an asterisk, put a bullet point, whatever you got to do. Take a picture of it. Graves' disease. Okay, it is hyperthyroidism or thyrotoxicosis, that thyroid storm, which I was talking about again. Increase in vital signs. Patients are sweating. Their heart rate's elevated. Their blood pressure is super high. Hypothyroidism. Okay, if somebody has a decrease in production of thyroid hormones, this could cause rapid weight gain. This could cause mood swings. Myxedema, exposure to inadequate levels of thyroid hormones results in changes in structure and function. Okay, there should be some pictures here. Oh, here we go. Graves' disease. Here's your signs and symptoms. Agitation, poor heat tolerance because they don't have any fat, weight loss despite increased appetite, weakness, difficulty breathing, tachycardia, protrusion of the eyeballs. So it's almost like their eyes are popping out of their socket. That's a really good indicator for potentially Graves' disease. So if you see that on a national registry test, increased vital signs, patients had recent weight loss, their eyeballs are very prominent, you should probably be leaning towards thyrotoxicosis or Graves' disease. It can also produce a diffuse goiter, which if anybody knows what that is, it's an enlarged thyroid. Literally, it looks like they have a giant lump in their neck. Like they seriously swallowed a baseball or a softball. I mean, it's massive. I wouldn't really call that bulging eyes. I'd just say that's somebody opening their eyes really wide. But there's your goiter, the increased size of the thyroid gland. Literally looks like somebody swallowed a baseball or a softball. Things to consider if you're being asked a scenario question. In the field, am I going to know any of this? If I see something like that, potentially, I'm going to go, oh, wait, I learned about this at one point. This is Graves' disease, maybe. Okay. Her eyes aren't popping out of her head, but we have a massive thyroid gland because, again, hyperthyroidism, thyrotoxicosis. Guessing her vital signs are going to be elevated. Thyroid storm. We were seeing this a lot in COVID patients. High fever. Weird. Delirium or coma. Tachycardia. Low blood pressure. I'm guessing we're tachycardic because we have low blood pressure. Our body's trying to compensate. Vomiting, diarrhea. The problem is our heart rate tries to compensate for so long, it increases our heart rate and trying to increase blood pressure. But when we're vomiting, have diarrhea, we have fluid loss, our blood pressure is not going to come up. Eventually, our heart is going to get tired. When that happens, these patients are dying. Supportive care. Treat the patient. Myxedema, coma, hypothermic, so they're really cold, kind of in a stuporous state. Can be fatal if respiratory depression occurs. Yeah, these patients are on obviously on a vent for long periods of time or permanently due to that endocrine disorder in itself with the thyroid. Things to look for. This is important. This is what I want you to remember. Unemotional, puffy face. Okay. Thin hair, enlarged tongue, pale skin that looks and feels like dough. So if you get a national registry question, and again, in real life, am I going to know if somebody has myxedema? No. But I'm telling you, I would probably know this when it comes to the National Registry question. You can see how their hair is actually thinning out around there as well. Tough, swollen skin. It's the easiest way to put it. Heart distress not uncommon. No, because our heart's trying to compensate, but yet it's not a heart problem. It is a fluid problem. There's three different things that lead to shock. We have a pump problem, we have a container problem, or we have a fluid problem. Well, this isn't a pump problem. It's not a blood vessel or container problem. It's a fluid problem. These patients need fluid. They need massive amounts of fluid, more than we can provide to them, but maybe that's what we're doing when we have them. Patients in a coma require intubation and ventilatory assistance. That should be any coma, not just myxedema. If there's concern for airway compromise, we take that airway. We now control that airway. Cushing's syndrome or Addison's disease, deficient adrenocortical activity. Okay, so I'm guessing I have a lack of adrenaline when that's happening. So what signs and symptoms am I going to see with Addison's or Cushing's disease? Cushing's affects middle-aged persons, women more than men. Weight gain, generally around the trunk of their body, so on their midsection. This, I remember this National Register from 7-8 years ago. Oh, God. This right here was how I remembered Cushing syndrome, moon face. They have a really round face. Accumulation of fat on upper back, referred to as a buffalo hump. That's what I mean. You saw this lady's face. See how round it is out around here compared to the rest of her head. Really narrow. But then we get this big round face. And what do we notice about her eyes? They're massive, right? I'm just telling you guys the signs and symptoms to look for, which will help you National Registry wise. You are going to have some sort of endocrine questions. I guarantee it. And it will be over either thyrotoxic storms, Graves' disease, Cushing's syndrome, Addison's disease. Addison disease, again, like I said, most likely inadequate, in my opinion, adrenaline. How am I saying that? Adrenal insufficiency. Okay, so my adrenal glands, they secrete adrenaline. If I don't have that, what do I essentially develop? Well, let's see. Hypoadrenalism. Oh, it can also cause hyperadrenalism. So what signs and symptoms am I going to see with this patient? I wouldn't remember Waterhouse-Friedrichsen syndrome, so don't even pay attention to that. Okay, progressive weakness, fatigue, decreased appetite, weight loss, hyperpigmentation of the skin, so they'll be very pink in color, and mucous membranes, very pink mouths, very pink tongues. How do we treat these patients? We treat them. We give them supportive care. We look for signs and symptoms. Emergency management, maintain ABCs. Okay, that's what we're taught early on as in EMT school. Close monitoring of cardiac and oxygenation status and blood glucose level. We should be doing that with any patient that's potentially having a serious issue. We treat and we monitor our patients the same. Again, it is our assessments that make us paramedics, not our skills. Hypoglycemia poses its own threat. Be aggressive in fluid resuscitation. You cannot give these patients enough fluid. Follow local protocols. I'm guessing you guys don't have a protocol for Addison's disease or Cushing syndrome. The big ones I think you will get tested on: Cushing syndrome and Graves' disease, because they have distinct characteristics. Graves' disease, they have the bulging eyes. They do as well in Cushing's, but they have a moon face in Cushing's. I'm not kidding you. I remember that specifically from my NREMT years ago, was having that question. And I remember answering and going, God, I remember this from class. Moon face was Addison's or Cushing syndrome. Think of it this way. Cushing's, they're really swelled up. They're like a big cushion. I hate to say that, but that's how I remember it. All right, first PowerPoint done. Not too bad. The good news for you guys is that the second PowerPoint over chapter 4 or chapter 5 is pretty self-explanatory, and there's not a whole lot that I need to explain to you. It's only 55 slides. I expect we'll get through it relatively quickly. It's over immunology. So again, allergic reactions. How does our body respond to allergic reactions? Okay, an allergic reaction is a response to a certain antigen. Our body recognizes a foreign substance. Remember when we talked about pathophys or whatever? Our body, the first time it's introduced an antigen, doesn't attack it. It tries to figure out what it is. So that way, when it comes back, it's studied it. It knows what its weaknesses are. That's how our immune system works. Your reaction could depend on how immune you are to certain antigens, which can range from hives to a full-blown anaphylactic reaction. Anaphylactic reactions being the most severe type of reaction we can have. The difference between an allergic reaction and an anaphylactic reaction, an allergic reaction can be hives. An anaphylactic reaction, in my opinion, is when you get the airway swelling, the difficulty breathing. That's your life-threatening emergency. Patient's tongue swelling up, life-threatening emergency. Allergic reactions can be treated with Benadryl all day long. Anaphylaxis needs to be treated with epinephrine, EpiPens. Or, my service, we don't carry EpiPens, we draw up Epi. Epi 1 to 1,000, 0.3 to 0.5 for our adults, 0.15 for our kids. Most common causes of fatal anaphylaxis, allergy status to penicillin. That's why it is important that we ask allergies. Now, when we ask allergies, most of the time people won't tell us they're allergic to bees, because generally we're not putting them in a bee-infested environment in the back of our ambulance. But when we're responding to a call for somebody that feels like it's getting hard to breathe, they're not sure what's going on, these are questions we should be asking based off the time of year. Are you allergic to any plants? Are you allergic to any bugs? Anything like that? How you assess your patient could be the difference between life and death for them. 400 to 800 deaths annually in the U.S. attributed to anaphylaxis. Again, there's a huge difference between allergic reaction and anaphylactic reaction. Allergic reactions are mild. Anaphylaxis is severe. Airway swelling, airway compromise. That person's tongue swells up to where you can't control their airway anymore. You couldn't even tube them if you wanted to. That's when we're kind of up a certain creek without a paddle. And if that happens, I hope you're really familiar with your quick trachs, or you're really familiar with a needle crikes, because you're going to be using it in those instances to just get an airway on your patient. All right, our immune system is what responds to allergic reactions. It combats infections. Its job is to literally look for foreign invaders, things that aren't normal, and it reacts to them. It might cause us to have a fever, because remember, we're trying to burn out whatever it is in our body that's not supposed to be there. Could cause us to develop hives, which is a release of histamine, which fights it. hence why Benadryl is an antihistamine to reduce hives. The chemical messengers, and again, there's some big words on here, and I hate it, but chemical messengers during an allergic reaction, the main ones, when we say principal, that's the main ones, are what are called immunoglobulins. Those are the messengers released during an anaphylactic or an allergic reaction in response to a foreign invader or foreign substance. Um, 5 classes of antibodies. I would probably know those. Write them down. IgA, IgD, those are different types of immunoglobulins. Ig is immunoglobulin. These are essentially produced by B cells. We call them fighter bees because that's literally their job, is to attack during an allergic reaction. Remember the difference between antibody and antigen. Antibody is what we build up in our body to fight whatever it is. Antigen is what essentially is the level of or something attacking us. You know, during a COVID test, you might have a rapid antigen test. You're looking to see if your body if that test is recognizing a certain antigen. If yes, your test will come back positive. If no, that antigen is not present, your test will come back negative. Antibodies then try to fight that antigen. Hence why, you know, they were saying if you've had COVID in the past, you might have antibodies built up for anywhere between 3 and 4 months. That's because your body has developed an immunity to it for a short period of time. It's recognized what it is and it's recognized how to fight it. But that doesn't last forever. Antibodies literally attach themselves to antigens and start ripping them apart in layman's terms. They start deconstruction of the antigen that's causing this reaction. Antigen is first entered the body. Dropping back to pathophys real quick. Remember that our first instinct is to try and flush it out. We'll sneeze, we'll cough. The next step is for our body to respond with its immune system. Antigen-specific antibodies more effective in the terms of COVID. And I'm just using this as an example because we know a lot about COVID from the last couple of years. The antibodies for COVID will only attack CoV SARS-2 because that's the antigen that it identified. If there was a CoV SARS-3, it wouldn't know how to fight that because it didn't identify that. It doesn't know what that is. So it's only specific to that certain antigen. Natural immunity, again, things that you essentially are just naturally immune to. In my case, it's poison ivy. I'm not sure why. I honestly have never looked it up. Acquired immunity develops over time, results from exposure to the antigen. You know, one thing they always talked about with COVID was herd immunity, constantly being exposed to it, which I hate to say is I think the big push behind the CDC kind of relaxing their mask mandates is because they're trying to get people exposed to it. It's not going anywhere. They realize that our bodies need to be exposed to it so we can develop antibodies, natural antibodies so that we can begin to combat it. Just like the flu, just like the common cold. Our body knows how to fight that. We have to be able to let our body do its job. Naturally acquired immunity develops after birth, enhanced by exposure to new pathogens and antigens throughout life. Okay, so it's things we become immune to. That's why we're not allergic to every single thing we come in contact with, because we've been exposed to them. Sometimes, obviously, there are things that maybe do cause allergic reactions with us. That's usually done through allergy testing at a very young age. Induced active immunity are artificially required immunity designed to provide protection from exposure to antigen at some time in the future. That could be a vaccine. Flu, COVID, whatever, I don't care, polio, any vaccine you can think of. They're trying to aggressively give you these antigens for your body to identify in hopes that your body builds up those antibodies and keeps it within by identifying that vaccine, by identifying the mimickers of that essential sickness or illness. Induced active immunity, in vaccination, the antigen injected in the body to generate immune response. A lot of times it's not the exact replica of the disease or the sickness itself. It is like, it's very close, but maybe might have one protein or one molecule that's different that prevents you from getting super sick. But it's close enough to where your body identifies it as an antigen. That way, if it sees that again, it knows how to fight it. Vaccines don't prevent you from getting something. All they do is try to get your body ready to fight it. All they do is train your antibodies. Hey, this is the wanted poster. It's holding up a wanted poster. This is who we're looking for. If you see this guy, this is how you attack him. That's what a vaccine does. That crap, and I don't care what's been spewed over the last couple of years, a vaccine does not prevent you from getting something. It is not possible. Now, could you maybe not have any effects from it? Sure. But you still have it. What was it? 3 weeks ago, I had COVID. 4 weeks ago, I had COVID. Would have never known I had it. I had taken a rapid test because I had a dentist appointment that day. And since I had a runny nose, which I get, or stuffy nose, which I get every single winter, it was not uncommon to me. My dentist made me go buy a rapid test. I did. It came back positive. I bought myself 5 days of sitting at home. I literally did nothing during the 5 days. I had no fever. I had no illness. If I hadn't got tested, I would have never known I had COVID.
You're welcome.
Yeah, thank you.
I really don't trust those rapid tests at all.
Do what?
I don't trust those rapid tests at all.
I took 3 of them, and they all came back and said the same thing.
Really?
Yeah. And then on day, I think it was day 6 or day 7, I had another one. I was like, oh, I wonder what these are. And it came back, and it was negative. So I kept the tests, to be honest, that I can to use just for teaching, to show how that actually works. And literally, I took a test. I'm not gonna lie to you guys. I took a test every single day for 6 days because they come in a 2-pack. So I bought 3 kits just to show how over time those antigens are slowly broken down. And I dated them. I put my name and my date on them just to be able to show, hey, at day 1, my antigen level was very high. Day 2 was a little bit lower because the line starts to fade. Day 3 was a little lower because my line was even more. By day 7, I didn't have another line. Even in sickness, I was trying to help by teaching. One that commonly we get as children is DPT. Prevents us, or not prevents us, but has a strong affinity for binding with diphtheria, pertussis, or whooping cough, and tetanus vaccine. Tetanus, obviously, we have to get, I believe it's every 5 years, unless you have been, I don't know, come in contact with a piece of rusty metal or something like that. They'll probably give you a tetanus booster. I remember, God, I was probably 18, 19. I was in my backyard, and we had one of those metal rakes. And when I say metal rake, I'm not talking the flimsy one. I'm talking like the real, like steel that has like the little round. I can't describe it, or maybe it's not a rake. I don't know. But it has like 10 teeth on it. Well, I wasn't paying attention, and I was mowing the yard, and I had backed up too close to the house, and that rake for some reason was laying there, and I stepped on it, and I was wearing sandals at the time. I know, not smart to mow in sandals. And that rake had actually went through my foot. I mean, it was like almost poking out the top of my foot. I could see a lump there. It was horribly painful. I went to the doctor. He looked at it. He laughed. He flushed it out, cleaned it, gave me a tetanus shot, and sent me home. That's all he did. I was current on tetanus, but he gave me a booster. Same thing happened to me 2 years ago. I stepped on a nail. I was wearing sandals while mowing. I might have just realized that I probably shouldn't be wearing sandals when I mow, because I always end up with something like that happening. So, but if that happens, you might have to get a booster. Now, diphtheria hasn't been around for a long time. Polio is the same thing as well. It's not as common as it was at one point, but we're still vaccinated for it. Acquired immunity can be active or passive, so it can be our body developing an immunity to it, or it can be through a vaccine. Most vaccinations result in development of active immunity. Absolutely. You were seeing people during COVID, at least I was at the service I worked for. We were doing a lot of transfers of patients that had COVID, maybe from a nursing home to a certain facility, and they were getting antibody infusions. We were calling them BAM transfers. I don't know if that's the correct term. Sarah, does that sound familiar to you? Were you guys doing those at all in Pella?
We weren't, but we heard you guys getting dispatched all the time for them.
For BAM transfers? Yeah.
Yes, over at Knoxville, yep, for BAM.
It was constantly bringing people from like a nursing home to the infusion center where they would receive these antibodies through people that had donated blood or whatever it might be, that had post-COVID, that had those antibodies build up, because that was a big thing was, hey, if you've had COVID, you can donate blood. It'll help people. And it actually worked really well. Not just there, but across the United States on helping some of those people that could become potentially super sick. I'm not going to keep covering antibodies. So obviously we get allergies to anything. Everybody's allergies could be different, and it depends on your response. My wife is allergic to eggs. Does she have an allergic reaction every time she eats them? No. She just gets a really bad headache every time she eats eggs. So your response kind of depends on what level of immunity you have built up to it and just what those symptoms are potentially going to cause. Hypersensitivity isn't so much of a allergic reaction, and I guess you could say hers is probably more of a hypersensitivity to egg, because it's a very minimal response, which is just that headache. Delayed hypersensitivity. This could be you maybe not developing a reaction for a while. If you guys have ever heard of, and I could be wrong on this, but like ACE inhibitor, some people over periods of time, long periods of time, I'm talking years, can develop an allergic reaction to ACE inhibitors like lisinopril. They can take it for years and be perfectly fine until one day they just have a reaction to it. Generally causes angioedema or tongue swelling. That could be considered.
Actually, I'm sorry to interrupt. Yeah. I've actually heard that with statins too.
Okay. That's a delayed response to something that their body just hadn't developed a response to yet. As to where immediate would be, I eat shellfish. I'm allergic to seafood. Why would I eat shellfish? My body is going to immediately go into a response. Drug allergies, the penicillin, certain types of shampoos, certain lotions, whatever it might be, can cause certain allergic reactions in different people. So that's why it's pretty important we ask about allergies. Some of the common, I would guess you could say, stressors of or allergens having to do with medications, drugs. Remember, IgE is your immunoglobulin E antibody. Foods additives. Some people might just be allergic to like red dye number 5. It's an ingredient in some things, so they can't eat anything with that. Certain animals. I'm allergic to cats. I'm not sure why, and it's only really long-haired cats for some reason. Every time I'm around them for a long period of time, my eyes get really puffy. I get to sneezing. I get really bad headaches. Um, Insects, so bees, wasps. Um, some people are allergic to certain fungi, maybe mushrooms, or certain radiology contrast materials. So if they're going to do like a CT with contrast, you could potentially have allergic reaction to that as well. So we know that there's so many different things that can cause allergic reactions within our patients. That's why it's important we ask about them. We should know what our patients' allergies are, at least as much as they tell us. Today we went through scenarios, or I went through a specific scenario. I haven't with the rest of you yet because we haven't got to it. But and one of the things that I look for is you're asking about allergies, you're asking about medications, and you're asking about past medical history. To me, I call those the big three. Those are huge when it comes to sample. And I ask about those almost, I don't wait 5 minutes to ask them, get in there and, okay, what's going on? What do I think's going on? I base my assessment around that. Okay, can you tell me, do you have any medical conditions and what medications you take for them? And if you know them, any allergies. I just asked all three questions in a sentence. It's not that hard. If they only list, well, here's what's wrong with me. Okay, do you take anything for that? And it doesn't hurt to constantly recheck that, maybe during transport. Okay, so the only thing you're allergic to is penicillin, right? I just want to make sure I get this right for my report, so that way there's no discrepancies. Well, actually, I'm allergic to latex as well. Okay, no big deal, but just rechecking what you already know, reassessing. Different ways that allergens enter our body. Orally, we can inhale them. Topically, through our skin. Injection or envenomation, so bee stings. Majority, again, plants or penicillin or bee stings. Well, right there, injection or envenomation. That's your penicillin, that's your bee stings. My little brother is allergic to penicillin. He knows that, and he knows every time he goes to the doctor, that's one of the first things he says to him. Hey, I'm allergic to penicillin. Okay. Different types of bugs. I'm not going to go through bugs. Fire ants, wasps, yellow jackets, hornets, honeybees, whatever it might be, could potentially cause an allergic reaction. And it's not so much the bug itself, it's the venom that they carry that you have a reaction to. I can tell you, I think it's yellow jackets or it's hornets. I can't remember which one that builds ground nests. I was mowing probably 6 years ago, a pretty large area, and wasn't thinking anything of it. The next thing I know is I'm getting like stung all over. And my first reaction was to abandon the mower and take off running. Well, my mower's a lot faster than me running, but I don't know why that was my first reaction. And I remember calling a buddy of mine, and I was actually mowing around my fire department. And I said, hey, I'm down here alone. I just got stung, I swear to God, by 47, whatever the hell they were. Can you head down here in case, because I couldn't think of the last time I'd been stung by anything. I said, hey, can you just head down here in case I start to have an allergic reaction or something like that, just to make sure that if I need to get like an EpiPen or something like that, to make sure I'm fine. It was just a precaution. Again, allergic reactions, we release histamine, we release heparin, so thins our blood out. Degranulation is when these cells, these allergen or antigens release histamine, when they release the chemicals that essentially cause a response within our body. We call it degranulating or breaking down. Again, the allergic reaction depends on the person and what they're allergic to. Most common thing that we see is histamine released during allergic reactions. Again, we have Benadryl. Literally, its name is an antihistamine. So what does it do? It counteracts histamine. Histamine produces vasodilation, bronchoconstriction, increased vascular permeability, meaning it makes our blood vessels almost like sponges. That's why people with allergic reactions become puffy, because their vessels are releasing all that fluid, not blood, just like fluid. We also become red because our blood vessels dilate. It changes our color. That brings blood to the surface when our blood vessels open up like that. Bronchoconstriction. They might have wheezing. Anaphylaxis, again, severe allergic reaction. These patients are having trouble breathing. How do we treat this? We give them epinephrine. Give them an EpiPen. Inject it with epi. Draw up epi. I don't care. Treat them with Benadryl afterwards as well, because I'm guaranteeing they're going to have hives. Treat them with Zofran if they're nauseous. Monitor them. You might have to give them a second round of epi. Results in asthma-like attack, occasionally asphyxia. Yeah, because our airway swells shut. We aren't able to breathe. Diagram of how our body reacts to antigens. Again, our blood vessels become very sponge-like. They release any fluid. We've become swollen around that area. We become very red around that area because blood is then able to come to the surface a lot easier. It's a lot of times hot to the touch, again, due to blood vessels opening up. Signs and symptoms can occur almost immediately, 30 to 60 seconds. Severity often related to the speed of onset. If it comes on very quickly, you're probably going to have more of a severe response, as opposed to if it takes 10 to 15 minutes for you to become itchy. That's probably all you're going to get. If right when you're stung, you start having difficulty breathing, that's bad. Watch that with your patients. That's why allergic reactions are true emergencies. Don't take your time with these. And I don't care what you know or what you don't know when you are going en route to this call. Treat it as though it's a life-threatening emergency if it's potentially an anaphylactic reaction. If it comes out as they think they were stung by a bee and they're having trouble breathing, you should probably get there in a reasonable amount of time. Per the law, drive with due regard, if you will, but get there quickly, because this can progress to them going downhill rather fast. Patients, any patients, I don't care if it's anaphylaxis or what, patients with sense of impending doom, think that they're going to die. That's something worth looking into. Quick, brief history should be gathered. The only thing I want to know if I think they're suffering from anaphylactic reaction is I want to know what potentially caused this. That's it. I'll give them the epinephrine. I don't ask about allergies or any of that because nobody's allergic to epi. I give them epi. Then afterwards, when they're able to breathe a little bit easier, able to talk, then I'll get into a sample and assessment. Other than that, I'm not making them talk and expel air and have trouble breathing during this event. It's the last thing I want to do. Common manifestation is angioneurotic edema. Again, angioedema is swelling of the tongue. You can't have swelling of the face. Anytime you see swelling of the face, assume that there's going to be swelling of the airway. Same thing with, like, if you think of burns. If there's burns to the face, you're assuming there's going to be burns to the airway. Laryngeal edema, so that is edema of the larynx or edema of the trachea. That's not good. That's swelling. May lead to complete airway obstruction. Absolutely. If you have to take the airway of these patients quickly, there shouldn't be any second guessing in your mind. If I see that massive tongue and the patient's starting to go unresponsive, I'm giving epi and I might consider intubating them really fast. I can justify to a doctor why I intubated a patient having an allergic reaction because their tongue was swelling. Now, if I give epi and intubate them and their swelling goes down, it might end up that I have to keep them sedated till we get to the hospital because we don't extubate people in the back of an ambulance, but I can justify why I did it. Now, please, for the love of God, do not go out and intubate your next anaphylactic patient. Give it a little bit of time to see if the epi does work. But I'm saying if it's severe enough to where this patient's unresponsive, gasping, give epi, secure the airway if you need to. A lot of times too, people might have anxiety to anaphylactic reactions or just to an allergic reaction and might freak out a little bit. This can cause them to think that they're having trouble breathing, but they might not be. Use end tidal on your patients anytime there's any sort of respiratory potential. Listen to their lungs. We're listening for wheezing. It'll be very prominent. You should hear them wheezing from across the room without a stethoscope. If you hear diminished lung sounds or absent lung sounds, that's not good. That means minimal to no air movement. Technical name for hives is urticaria. Probably should know that because they might not say hives on testing. They might say urticaria. If left untreated, obviously this could lead to a patient having cardiovascular issues. This could lead to a patient going into respiratory arrest. This could lead to a patient dying if left untreated. Good example of hives. To me, that looks like they got into poison ivy, poison oak, whatever it might be. Remember that poison oak, poison ivy, or whatever, it's very oily. Remind the patient not to touch the rash and then touch other parts of their body. They could potentially spread the rash because their other parts of the body will have a response to that oil. Again, treat your patients with Zofran. Treat their symptoms. I can't preach that enough. They're having nausea, vomiting, and diarrhea. I can't help your diarrhea, but I might be able to help your nausea and vomiting. Vital signs, yeah, we should be monitoring these patients if they're having an anaphylactic reaction. Cardiac monitor, end tidal, pulse ox. It says if patient intubated, end tidal carbon dioxide detector. They're speaking of a detector alone. Put your patient on end tidal. It makes you a better paramedic. Again, end tidal levels, 35 to 45 is normal. Anything above, we could potentially see our patients holding on to carbon dioxide due to maybe inability to breathe or inability to process that carbon dioxide. Anything lower could be our patients over breathing and getting rid of too much carbon dioxide when we don't want them to. Either way, increase in carbon dioxide is acidosis. Scene safe. Make sure, in my case, there's not 47,000 whatever the hell stinging you if you roll up there. Just be cautious. I hate saying scene safe. That's something we should automatically do. But obviously there's the reason we brought it up is because some people don't. Honeybees, if you need to remove the stinger, credit card is the best way to do that. Don't try to grab it with like tweezers or fingernail clippers or any of that. Credit card and just kind of scrape it. Should be able to pull it out. We want to try to remove the stinger if possible, just for the simple fact that while it's in there, it still has venom on the end of it. It could still be producing that reaction with our patients. If you think they sustained trauma from an anaphylactic reaction, maybe they fell, whatever it might be. In my case, I jumped off the mower. Maybe I, could have rolled down the hill and broke my leg or hit my head really hard on something. I'm unresponsive. You pull up, what do you notice? 47,000 bees flying around. I'm unresponsive. You think allergic reaction right away, and bypass the fact that I might be unresponsive because I smacked my head on the curb. ABCs. I can't say that enough. Protect the patient's ABCs, airway, breathing, circulation. If there's a problem with the airway, you don't go to breathing. You fix the airway. If there's a problem with the breathing, you don't go to circulation. OPAs, NPAs, obviously if there's trauma, we're probably not, facial trauma, we're not considering an NPA. going straight for the OPA at that point. If need be, like I said, and this is surgical airway. As a paramedic, it's not in scope of practice in the state of Iowa to do a surgical airway. That's a CCP, but we do have quick crikes or quick trachs, and we do have needle crikes. My problem with needle crikes is that's a 10 to 14 gauge catheter. Try to hook a BVM up to that. It's impossible. So when you do a needle, have you guys all been through needle crikes as far as skills yet? I know I went through it with the Mason City group, but here in Des Moines, have you guys done needle crikes?
Yes.
Okay. What did you guys find out about needle crikes? What was it? Were you able to bag through it? Could you effectively BVM a patient through that?
It was hard.
It was hard, right? So my service, we don't carry quick trachs. We carry needle crikes. No matter what size catheter it is, a 2.5 millimeter tube top is the only one that'll fit in a catheter, just for reference. So literally my crike kits have 10 gauge and a 2.5 ET tube top. Can I ventilate through it? It is hard as hell, but it's some air movement. It's better than nothing. Establish IV as soon as possible with these patients. It might be a little more difficult because they might be swollen due to the allergic reaction. Treat the patient. If they're hypotensive, give them fluids. On severe patients, we should be doing 2 IVs anyway. I love 2 IVs on cardiac patients. They're necessitated in trauma patients. Anything where I'm going to be giving fluid, I like having 2 IVs because one IV I can give meds through, and the other one I can just leave the fluid flowing. Epinephrine, epi 1 to 1,000. Again, adults 0.3 to 0.4, 0.3, 0.5 milligrams. EpiPen juniors or EpiPen for kids, 0.15. Works pretty quickly. Remember, it has alpha properties, so we're going to see vasoconstriction. It has beta 1 and beta 2. Beta 1 being the heart squeeze, one heart, beta 1, and then beta 2, I have 2 lungs, so it's going to increase bronchodilation. In histamines, Benadryl, advise your patients after you give epi and after you give Benadryl. You know, epi can cause headaches and can cause them feel like their heart's racing. Benadryl can make them very sleepy, almost tired-like. Make sure you're telling your patient if they start to feel any of those symptoms to let you know. That tells you that essentially that medication has kicked in at that point. Corticosteroids, I love Solumedrol. I give Solumedrol to any patient experiencing a respiratory problem because, again, it's a steroid, could reduce inflammation in those patients. Am I going to see that inflammation reduced? Probably not. But once they're at the hospital, you'll see the hospital will begin to see the effects of that steroid kick in. Vasopressors, we're probably not so much going to be doing on anaphylactic patients in the short amount of time we have. Maybe if you're doing IFTs or interfacility transfers, you know, maybe you're going from Pella to Des Moines, or from Skiff to Des Moines, or Knoxville to Des Moines. Maybe if it's such a severe reaction that they're having trouble maintaining blood pressure. But at that point, you'd just be doing a maintenance medication. Remember, norepi and epi are common hormones in our body, as well as dopamine. Dopamine causes us to be happy. So the patient having an allergic reaction to those is not there. Duonebs. Use Duonebs. Patients wheezing, use Duonebs. My protocols specifically say that I can only give 1 Duoneb and I have to follow up the rest with albuterol. Remember, there's 2 parts to a Duoneb, hence the word duo. You have albuterol, and you have usually 2.5 milligrams of albuterol, and then you have 0.5 milligrams of ipratropium bromide, which is more of a drying agent or also a steroid. Its main job is to dry up any secretions. That way the patient can cough and kind of clear up their lungs a little bit. Other agents, vasopressin is not a drug carried anymore. Atropine, maybe this is a organophosphate issue. We have to give atropine. Glucagon reverses the effects of beta blocker overdoses, but again, that falls more under overdoses than it does allergic reactions. And remember, this is huge. Tell the patient about potential side effects that they are going to encounter. It gives them a heads up of what they're going to feel. And when they start feeling that, ask that they notify you so you know what's happening. Allergic reaction will have more gradual onset with mild signs and symptoms. Yeah, allergic reaction is mostly just your hives, slight swelling. You're not really going to have so many respiratory signs with it. That's more going to be itchy, rashy. Think your poison ivy. If they start to exhibit wheezing or difficulty breathing, I'd say that's probably a trip to the hospital, and we're going to monitor their airway pretty closely. You might just have to do a Duonym, and if that clears them up, great. But again, monitor their patency of their airway. Epinephrine 1:1, I think I've beat the dead horse on that. Intramuscular route, 90-degree angle. If you want to educate your patients, you can. Generally, I don't think that's the time when they're having an allergic reaction. I'm not going to sit there and scold them, but what they're saying is that many are preventable, which I would agree. But there are times where somebody just is unaware of what happened, or maybe they went to a restaurant and failed to advise the restaurant that they had an allergy to something. If they gave an at-home EpiPen, if you hear on dispatch, hey, patient said they gave themselves an EpiPen, to me, that, like, if I'm responding to that, I have two questions in my mind. One, did they truly need the EpiPen? And two, I should probably prepare more Epi in case I have to give it. So it can go one of two ways. Either they didn't need it and they gave it to themselves because they got worked up, or two, I'm gonna have to give more Epi because their reaction was so severe that it's probably gonna come back. Paramedics often keep reference cards for anaphylactic patients living in their service area. I don't think so. I can't, unless your service does, speak up. I don't know. Out of anywhere I've worked, I can't say that I had a reference card for every single patient's allergies or those that cause an anaphylactic reaction. I can't say that happened, and I can't say that that patient came to the fire station willingly to try to turn in their medical history. All right, 2 chapters done, not too bad. Let me get the screen back. Chapters 4 and 5, the PowerPoints are on D2L. I can put some handouts up there for you guys if that'll help. But there's really not a whole lot of like visual information for me to put for any guidance or anything like that. Immunology should be nothing new to you. Yeah, endocrine had a lot of crap in it, a lot of new stuff, but find the way that works for you to study. Maybe it's taking medic tests, maybe it's reading the book, maybe it's reading your notes. Whatever works for you, you've got to find that groove. I can't tell you what works for you. It's just, there's no way. Everybody studies differently. Next week is, I'm trying to remember what it is. Infectious diseases. It's a long PowerPoint. I want to say it's 180, 190 slides. Shouldn't take us but 2.5 hours roughly. I hate keeping you guys anything over 3 hours, anything over 2.5, because honestly, you start to lose focus. And especially at night, you want to get off at some point. After next week, you will have another exam. It will include chapter 3, 4, 5, and 10. 10 will be infectious disease. I believe it's 50 questions as well, worth 50 points, and it's going to cover all those chapters. So what is that? 4 chapters, 50 questions. So something like 12 questions per chapter, covering each one on average. What questions can I answer for you guys? I know it was a lot of information tonight. Some of it might not be new information. Some of it's stuff you already know. You already been through with pathophys. Infectious disease shouldn't be anything new to you either. It's probably stuff you know, especially the world we've lived in the last 2-3 years. But again, there is some information that is pertinent in there. Like I've said before, I try to, if I think it's National Registry worthy, I try to kind of give you a hint that you should probably be paying attention to that because it could potentially come up on your National Registry. Problem is anything can come up in your National Registry. I don't know what's going to come up. That's why it's important to, if you don't understand something, look in your book, ask a paramedic you work with, see if they can put it in better terms. That really falls on you guys. Any questions I can answer for anybody?
Rudy, it's not about this, but next semester, how does it work with like the capstone?
Mhm.
Are those in addition to the hours that are listed?
So capstones are more of a competency. God, I don't have the handbook in front of me, or else I'd look at it.
That's okay. It's just been kind of a burning question. I was just curious about
No,
how
you're
that all
fine.
works.
Let me look at the handbook, and I will send an email out to everybody defining capstones and kind of what it means in layman's terms. And that's something that I've always kind of been iffy on how that all works. So I'll probably have to ask Cheryl for interpretation of the handbook, so that way I can interpret it to you guys. We didn't have capstones when I went to paramedic school. We had team leads, which is essentially what a capstone is. We had to have 50 of them throughout the entire program, and we couldn't start them until second semester. The problem is the only reason we don't allow you to start them till third semester is that we are governed by an agency called COA. They oversee all the education standards for healthcare. COA has dictated that you cannot be a team lead until you have all of your core content. Well, the problem is all your core content is in first and second semesters. So what we hope is that by third semester, yeah, you're doing your third semester hours, you're maybe finishing up clinicals you didn't have, finishing up competencies here and there, but that your focus should be on getting those team leads, if that makes sense. But I can send out a little bit better definition probably tomorrow.
Okay, thanks.
Thank you, Rudy.
Yeah, you guys have a good night. For those of you Thursday night that are in class, we will just a brief heads up for you guys. If you're not in the Thursday class, if you're not in the Thursday class, you can take off. Have a good night. Sayonara. I'll see you guys when I see you next week or whatever. For the Thursday night group, we are testing your competencies this week. There will be 4 stations. I'm just gonna give you a heads up so we can kind of move fast Thursday night. 4 stations, 4 evaluators. It'll be myself, Cheryl, Liam, and then G, who is a new full-time faculty with the college. You will have to go to 2 stations and go through and essentially run through a scenario. You will be by yourself. There will be nobody with you. Each one should last 5-6 minutes. After you're done with the 2, you can go home. Should be fairly quick. We have to test you guys on competencies to get you guys your yellow cards, and we also grade you on your competencies, making sure that you Can read a 12 lead, making sure that you can identify certain trauma conditions, making sure you can neurologic conditions such as strokes or seizures. So those are the things that we're more likely going to be testing you on. But again, just so it moves a little bit quickly on Thursday night. On the whiteboard, you'll see room numbers and names next to the room numbers. That's which instructors in which room. There is a blank. There will be a blank spot next to that. So let's say I'm in room 16. You would go put your initials next to 16. So that way anybody looks at the board, they know that you're in that room. When you come back out of that room, you go back to the classroom, you erase your initials. So that way somebody knows the room is open. When you go to the next one, you just put your initials for that room number, if that makes sense. Just so that way, because nobody's gonna be in there with you. That way we're facilitating who goes to what room, and it's kind of like just policed by you guys. Other than that, if you don't have any questions for me,